welcome to NIPFP and very, very good afternoon. We have our esteemed guest, Dr. Gruber. So thank you for agreeing to talk on US healthcare reform, past, present, and future. So, Dr. Gruber, we all know him. So just for formality, I will mention a few words. Dr. Gruber is the fourth professor of economics at the MIT, where he has taught since 1992. He is also the director of the healthcare program at the National Bureau of Economic Research and president of the American Society of Health Economists. He has published more than 160 research articles, has edited 6 research volumes, and is the author of Public Finance and Public Policy, leading undergraduate text, which I have read during my undergraduate course, so I hope many others also public economics. And the healthcare reform or graphic novel. So in 2006, he received the American Society of Health Economists inaugural medal for Best Health Economist in the nation, aged 40 and under. During 2009 and 10, he served as a technical consultant to the Obama administration and worked with both the administration and Congress to help craft the Patient Protection and Affordable Care Act. So with this, I stop here. There are many other things which we all know about you. So
thank you.
Thank you.
Thank you. It's great to be here. Thank you all for inviting me. I want to start with a great weakness, which is that I talk much too fast. And in particular, if I'm not interrupted, I talk faster and faster. So it's very important. I really like people to ask questions, make comments, etc. as I go along. Poor Mita, this is the 4th time she's hearing me talk in 3 days, so she's excluded. She can go to sleep. But the rest of you, I'd like you to please, if you have any questions or any thoughts, please interrupt me, or I'm just going to go faster and faster, and you won't understand me. So what I want to do is talk about healthcare reform in the U.S. And what I thought I'd do is talk about the general set of issues around healthcare reform. I don't want to focus too much on the U.S. details, because I really want to focus more on the process and sort of, how healthcare reform works. And I want to dive into an example of how hard it is to actually design a healthcare reform, because to realize how many questions you need to answer to actually do healthcare reform. So I call this pulling the thread, because healthcare reform is like pulling a thread on a sweater. Because when you pull the thread, the whole sweater can fall apart. And basically, every decision you make can affect hundreds of other decisions, and they all work together. And so essentially, the fundamental tension in healthcare reform is between a partial reform, where you attack one problem, but that kind of affects all through the system that you may not intend, versus a global reform, where you fix all the problems, but you can never pass it politically because too many people get upset. And that's sort of the tension, is basically seeing that. So in some sense, the key issue is, how do you do what needs to be done while recognizing that it might not be perfect? In the US, we have a saying, don't let the perfect be the enemy of the good. Good is good. It's okay if it's not perfect. And how do you go forward with what's good? So that's sort of what I want to talk about. So let's talk about the example of US reform. And once again, I don't want to talk a lot about the US. I'd rather, if you have questions about the US, please ask them. But I want to talk more about the general theory of healthcare reform. So let me talk a few minutes about the US. So the US has been trying to reform its healthcare system for 100 years. Teddy Roosevelt in 1912 was sort of the first, earlier than that, was sort of the first proposal for universal healthcare reform, and then on average every 17 years, presidents have tried to reform healthcare and it never worked. And the reason it never worked is it got stuck between 2 extremes. Okay? On the one extreme is a single-payer system. That's like what Canada has. It's what you would call the trust model. Okay? Essentially, the idea is the government is the insurer. There's no insurance companies. The government's the insurer. And basically, when you go to the doctor bills the government pays. Okay? And Canada is the best example of that in the world today. It's actually rarer than you think. Very few countries actually have a pure trust model. Canada probably is the best example. Okay? Now, that has a lot of advantages. And in particular, if you do that kind of system, you can solve a huge number of problems. But politically, it's incredibly difficult in the US. Okay, it's incredibly difficult because there's three hurdles, if you will, you have to get over. The first is that health insurance works for most Americans. So in America today, 60% of people get health insurance from their employer. Either 60% of people from their employer or a family member's employer. So 60% of people have health insurance from their employer. That's generally pretty good insurance. 20% of people have health insurance from the government. That's generally pretty good insurance. So it's really only about 20% of people who don't have access to good health insurance. So the problem is, if you want to do single payer, you've got to take 80% of people and take away something they like to help the other 20% of people. That's not very politically easy. Okay, I think we understand how democracies work. Taking something away from 80% to make 20% happy doesn't work very well. That's the first problem. The second problem is the economic incidence problem, which is, as I said, 60% of people have health insurance from their employer. How is that paid for? That's paid for by employers paying their employees lower wages. So MIT spends $12,000 every year on my health insurance. It's a lot of money. Okay, they don't do that because they're nice people. They pay me $12,000 less in wages. Now, they don't say they're going to do that, but we know from studies that that's what happens. That when health insurance gets more expensive, employers pay less. So we can call that a hidden tax. There's a hidden tax financing health insurance. If you do single payer and get rid of employer insurance, the good news is the hidden tax goes away. The bad news is to pay for it, you need a not hidden tax. And the not hidden tax, voters get mad about. And economists can go to voters and say, but wait a second, don't worry, it's just replacing a hidden tax with a not hidden tax. They don't understand. So for example, we have 50 states, as you know, and one of our states is Vermont. Vermont is our most liberal state. Okay, so Vermont decided they would try to do a statewide single payer. In that state, it's where Bernie Sanders is from, you know Bernie Sanders, it's our most liberal state. Okay, so they asked me to do the calculations for what it would cost them. Do the sort of modeling I'm now doing with Mita and you all and the team here for India. So I did the model and I said, well, there's good news and bad news. The good news is if you move from your current system to single payer, your total healthcare spending will fall by 10%. And the reason is administrative savings. You'll save a lot of administrative costs by having a single payer system. The bad news is you'll have to raise taxes by an amount which is more than the existing entire tax collections of the state of Vermont. You'll have to more than double your taxes. And they said, thank you very much, go away, we're not doing this. So the problem is that people don't like taxes, and they don't understand that you're replacing this hidden tax with a not hidden tax. That's the second problem. The third problem is we have a very, very large private health insurance industry. It's related to the first problem. $800 billion a year. They aren't going to go away quietly. They aren't going to say, sure, whatever, we'll go out of business. They're going to lobby and work hard to not let this happen. So for those reasons, single payer has been very hard to get in the US. And for many, many years, we have let the perfect be the enemy of the good. We said single payer or nothing. So we've got nothing. On the other extreme, you have people who say the free market will solve this problem. Let's just have a free healthcare market. The problem is, remember that for 20% of the people, the free market has failed. And you know, we know, and if you've studied health economics, know that there's no place with more market failures than health economics. Maybe environmental economics is number one, but healthcare is number two. Okay? And the famous article on this, that Ken Arrow, who's the Nobel Prize-winning economist in 1963, wrote a classic article laying out all the healthcare, all the market failures in healthcare. And for those 20% of people, health insurance was not available. What I mean by that is we had an individual market like you have in India. About 1% of people buy individual health insurance in India. But that market, much as like in India, was highly discriminatory. If you'd been sick, they could deny you insurance or charge you many, many multiples of other people. Or they could just say, we won't cover your pre-existing condition. So my wife had breast cancer when she was young. She's healthy now. But if we tried to get health insurance, they could say no. Or they could say, fine, we'll give you health insurance, but we're not going to cover anything related to cancer. So if cancer comes back, tough luck. Well, that's not insurance. Okay? So the system was fundamentally broken. And the free market wasn't going to fix that. You need government regulation to fix a broken system like that. So that's where we were stuck. We were stuck between an ideal, which was politically impossible, and something which was not solving the problem. Now what we did in America was we figured out a middle ground. And the hero of this story here was Mitt Romney. You might have heard of him, he ran for president. Before that, he was governor of Massachusetts. And as governor of Massachusetts, we used to in America, there's an endangered species in America. It's called a sensible Republican. Okay? There used to be sensible Republicans. Okay? Mitt Romney was the classic example of that. Okay? He was basically an engineer. He wanted to get things right. And he figured out a solution. His solution was, let's take the 80% of people for whom the system's working, let's leave them alone. And let's build a structure that fixes the system for the 20% of people for whom it's not working. Now, for those 80% of people, there's some small problems, but we're just going to leave those alone. At the same time, we're not going to bother them. So what he did was he built what I call the three-legged stool. The first leg was saying insurers can no longer discriminate against the sick. Insurers have to offer insurance to everyone at a fair price. Okay? Now, in fact, he was not the first person to think of that. A number of states, 7 states in the U.S., tried that in the 1990s. But in every state, it destroyed the insurance market. Because insurers said, wait a second, if we can't charge the sick more than the healthy, then we're going to lose money, so we're leaving. So insurers exited, the market got destroyed. Do you have sports, do you have cricket betting here? Do you bet on cricket matches?
No, it's illegal, but you can do
Okay,
it.
so we understand how sports betting works. Here's the analogy I like to use. So in the U.S. we have our American football, and the way it works is people aren't supposed to, but they bet on the American football, and the gambling agents, we call them the bookies, okay, their goal is to have an equal distribution of risk. They don't want to take any risk. They want the same number of bets for win or lose. So when they do that is they set what's called a point spread. So let's say my team is much better than Mita's team, and they're going to play. So what they say is, if you want to bet on Mita's team, I'm going to give you a higher prop. I'm going to give you more money if you win than if you bet on my team.
More odds.
More odds. British odds.
Yeah.
Better odds. Okay? Now, let's say that I passed a law which said that halfway through the game, people could place new bets, but at the old odds. So let's say it was halfway through and Mita was suddenly beating me. Ozzy would suddenly bet money on Mita, and the bookie would lose, would get killed. That's what these laws said to insurers, right? Insurers are like bookies. They just want a distribution of risk. They don't want to take a risk. And these laws are saying insurers that people know they're sick, but you have to charge them the same price as the healthy. And insurers said, forget it, and they left. That's why we need the second leg of the stool, which was the individual mandate. The individual mandate said you were going to force everyone to buy health insurance, whether they're sick or whether they're healthy. That way insurers can be sure that they'll get everyone in the pool, and they can price it fairly. Thank you. We definitely don't get this at US seminars. So insurers can make sure that they'll get a very fair distribution of risk. So that's how Romney addressed that problem. But that introduced a new problem, which is you can't mandate people to buy health insurance if they can't afford it. That's why we need the third leg of the stool, which was subsidies to make health insurance affordable. So for people who were below the typical income level, we helped pay for their health insurance. Those 3 legs worked together in a system that worked very well. So in Massachusetts, we had uninsured people, we covered 2/3 of them. We covered, only 1/3 were left. So that's pretty good. Not perfect, but pretty good. And it worked well enough that in fact other states wanted to do this. And I was saying, Nita heard this story already, but probably the highlight of my life. So you guys, I understand like American action films are big here, like XXX and things like that. So when I was young, the big American action hero was Schwarzenegger, Arnold Schwarzenegger. Has anybody heard of Arnold Schwarzenegger? Okay, big action hero. He then became governor of California. So I got to go out and work with him, which was a thrill for me. And the highlight of my life is one of his most famous early movies called Conan the Barbarian. And he has the sword from Conan the Barbarian. You can hold it. So I got to hold the sword from Conan the Barbarian. It was very exciting. So I worked in California and other states But the problem was the other states couldn't make it done because there wasn't enough money in the state. Massachusetts, we had an advantage. We had a very low uninsurance rate. So it was cheap to do it. California was too expensive. So that's why when Obama got elected, he decided he would try to take the Massachusetts approach, even though it was a Republican who did it, Mitt Romney. Obama said, even though I'm a Democrat, I'm going to take that Republican approach and apply it to the national level. And that became the Affordable Care Act. And so basically, that was essentially the process that we got the Affordable Care Act. Now, one important point to recognize about US politics is we have a huge advantage, systematic advantage, which is something called the Congressional Budget Office. Before 1974, when politicians made proposals, they got to announce how much the proposal would cost. So in 1965, President Lyndon Johnson proposed something called Medicare. That's now our insurance for the elderly. He got to announce it. He got to announce how much it would cost, and he just made up a number. In fact, he lied. He knew it would be more expensive than it was, but who was going to tell him otherwise? And it got passed. That's not the way to make policy. So in 1974, we set up the Congressional Budget Office. They're an independent group, which when proposals are made, they give an independent number on what they're going to cost and what effect they're going to have. And they have a huge effect on the Washington debate. Huge effect on the Washington debate. And what they do is they have what's called a micro-simulation model. They essentially have a model where they take assumptions about economic behavior. And they say, okay, given those assumptions about economic behavior, how will this policy impact spending, outcomes, things like that? Okay? And so my job in this was that the CBO is understaffed. Okay? They have a lot of things they need to do. So what Obama did is Obama said, I want to have a plan like Massachusetts, but I'm not going to figure it out. I'm going to let Congress figure it out. I'm just going to give a few parameters. It had to cost less than $1 trillion over 10 years. A few parameters. And then Congress had to figure it out. Well, Congress had hundreds of decisions to make. And they wanted to know, for various combinations of decisions, what it would cost. But, literally there was an infinite number of possibilities. And CBO said, we're not going to tell you that. You come to us with a final plan, we'll tell you what it's going to cost. So my job was, I had a micro-simulation model that was like CBO's. And I was essentially the pre-CBO. So I spent several months, essentially Congress would come to me and say, here's 50 options, tell us what they're going to cost. And we'll pick the 3 we like, and then we'll move on from there. So I got to sort of help narrow the options before it went to CBO for the final scoring. And that was very exciting because what I realized is, I think this is true in India as well, in politics a good number is worth 1,000 words. That if you can go to a politician with a good number and say, this is what it's going to cost, that's what matters. Meeta was saying she wrote a quick note after the Modi proposal on what it would cost, and that number got a huge amount of attention. I think that basically having numbers of this type are very important, and that's why part of the reason I'm here is I'm working with the Gates Foundation to try to develop a model like this, with Gates Foundation and with the team at NIPFP, to try to ultimately develop a model like this that would be housed at NIPFP that could play the same function that CBO plays in the US. Could actually be an honest broker. So Modi doesn't just tell us what his proposal will cost, we actually have an estimate from objective sources on what it's going to cost, and for any sort of proposal. So that's sort of the goal, and that's what I got to do in the US, which was very exciting. So that's sort of where we are. Now, the Affordable Care Act has been in place now for a few years, and so the question is, has it worked? Well, it depends on your perspective. Certainly it's not perfect, but it's also definitely been better than what was there before. So we covered almost half the uninsured, which was great, and we did so in a way that was actually below budget. So that was all very good. The bad news is that it became very, very partisan. Even though this is a Republican idea, remember Mitt Romney is a Republican, once Obama adopted it, the Republicans said it was terrible. And they attacked it endlessly. And it turned out to not be sufficiently politically robust. And this is an important lesson as we think about reform, especially less of a problem in a parliamentary system. But it's a problem in any system that if you have a reform that has continuous opposition, it's hard to make it work. In particular, if you think about the mandate, that's something which only works if people believe in it. If people say, I'm not going to do the mandate, that doesn't work. And basically the law, they never got politically enough support. So now that Trump's elected, he's sort of cutting back on the law. Now he's doing various things. It's not clear exactly what will happen, but the best estimates are he's going to cut the effectiveness of the law by between a third and a half, which is really bad. So because of Trump, between 6 and 10 million people will lose health insurance, which is really unfortunate. Hopefully the next president can do things to bring it back. So I think the lesson is, politics matters. I don't think that's a surprise to anyone, but unfortunately it did here. So that's kind of where we are in the U.S. in terms of kind of the healthcare reform. What I want to really focus on, and once again, I'm happy to answer any questions about the details of that reform and how it worked and stuff. So if you have questions along the way, please let me know. What I want to talk about now, focus on today, was how hard it is to actually go from an idea, like the Modi proposal, to an actual cost estimate. How hard it is because it turns out there are hundreds and hundreds of decisions that have to be made. And I think politicians don't appreciate that an announcement like we should have health insurance for all poor people only starts the conversation. And below that, there needs to be hundreds of decisions made on what that means. So what I want to do is talk through an example of what it means to actually make an announcement. So for example, let's say that you announce you want to subsidize health insurance, which as we did in the US. The subsidy could be 100%, it could be free, it could be 50%, whatever it is. Let's say you announce you're going to help lower the cost of health insurance. Okay? This is a similar feature to what Modi's proposing. Okay? This simple announcement raises hundreds of questions. Let's go through some of them. First, what is insurance? What does it mean? I mean, the number out there is that it costs up to 5 lakh. Well, what does that mean? Cost up to 5. Cost of what? On what prices? So, for example, what services are covered? In particular, are you going to specify a particular benefit package, or are you just going to say it has to be generally this generous? So in the US, we call this actuarial value. Actuarial value is a concept which tries to summarize in one number how generous insurance is. What it means is if you take an insurance plan and apply it to an average population, what percent of its cost will it cover? So for example, take a plan which covers all your healthcare needs, but where you pay in the US, but where you pay the first $2,000, a $2,000 deductible plan. That has an actuarial value of about 85%. What that means is that an average population, that the insurer will pay 85% of the costs and the people will pay 15% of the costs. That's on average. Now if you're healthy, the insurer will pay nothing and you'll pay everything because you'll be below $2,000. If you're very sick, if you spend $1 million, then you're paying basically nothing, the insurer's paying everything. On average, the insurer pays 85%, you pay 15%. So one way is just say, look, we're going to have a plan which is basically this generous, 85%. And we'll let insurance companies figure out how to design it. Or you could say, no, we're going to have a plan which covers these specific services, has this specific cost you pay for each service, etc. So that's one decision you have to face. Once you go down that road, however, once you don't just say generosity, but actually say specific benefit package, then you have to fight over what benefits are included. And this was the biggest fight we had in doing healthcare reform. So in Massachusetts, and the Affordable Care Act, the law was very, very vague. So the law in Massachusetts, for example, said there should be universal coverage with a generous benefits package, and we're not going to define what that is. What we're doing instead is set up a committee of 10 experts that's going to figure that out. And I was one person on that committee. So that committee had the job of figuring out what should the insurance package be. And we had to fight for many months over what should be included. In particular, those fights come in two forms. The first form is a fight about affordability. Because the more generous you make the insurance, the more expensive it is. And since the state is subsidizing the insurance, the higher the fiscal cost. So here's an example. In the US, everybody agrees insurance should cover doctor and hospital and drugs. But what about dental care? There's a lot of controversy. A lot of Americans don't insure for dental care, a lot are. So we spent a lot of time looking at it, and the actuarial experts told us that if we added dental care to the package, that would have raised the cost by 10%. And we decided that's too much. That's too much, you know, our goal is to be fiscally responsible. That's not fiscally responsible, we won't do it. So that's one issue. The harder issue is morality. Yeah, I'm sorry, go ahead.
So, what were you weighing it against? So 10% was getting you so much more life expectancy, so much more DALI. What were you weighing it against?
That's a great point. Nothing that rational. So in some sense, what you'd like to do is exactly what you'd like to say. You'd like to say, what is the health benefit versus the cost? Dental, that's hard. You're not saving anybody's life with dental care. So it's really about quality of life. We weren't doing anything that rigorous. It was more just a judgment call of kind of, look, what do we think, how high do we want premiums to be under this program? And what are we willing to sacrifice to keep premiums manageable? But rationally, you want to do that. The problem is once you go down that road, you've got to measure value, which is really, really hard. I mean, we have theoretical concept, DALIs is, adjusted value of your life, basically. That gets very hard because those are very imprecise calculations. But that's what you'd want to do in principle. You'd want essentially, for every element, weight the cost versus the quality of life improvement. One reason that's very hard is the quality of life improvement is incredibly heterogeneous across people. So the quality of life improvement, for some people with bad teeth, fixing their teeth can get them a good job and improve their life enormously. In America, if you have very bad teeth, it's hard to get a job. People sort of grossed out by it. So, well, we weren't anywhere that precise, but that's what you'd like to do. So that's sort of an example of one kind of problem. The other problem is sort of ethical or moral, which is some people have moral views about what should be included. In the US, the big debate here was over contraception, birth control. Some religious people don't believe they should use birth control. And they were upset about a plan which insisted that it include birth control. Now, talk about a value. I mean, that's a clear value. Birth control costs nothing and it saves a huge amount of medical dollars. So in any criteria about quality of life, it should clearly be included. But there was a big morality discussion. In fact, Obamacare, we did mandate contraceptive coverage, and it's one of the most controversial aspects of Obamacare. And that the case actually went to the Supreme Court, okay, because people were very upset about this. So a small number of people, but they felt very strongly. So what is covered is an issue. What specific services are covered are an issue. Where are they covered? Are we going to cover care at every location? Only at hospitals? Only at clinics? Does it depend on the nature of the condition? Will you cover, for example, cancer only in hospitals, but the flu only in clinics? Or will we cover everything everywhere? Or will we only cover hospitals for anything? So, for example, these state schemes, like in AP and other places that have health insurance, are only for tertiary care. Right? They're only covering the most expensive, most significant, the cases that are treated at tertiary care facilities. That's a decision you have to make. Within that decision is another very important decision, which is how much are you going to limit where people can go? Are you going to have an open network? Or will you be like ESIS, where you just go to a certain number of facilities that are, say, owned by the insurer or contracted with the insurer? This is a very, very important conversation. Indeed, over the last 8 years, healthcare spending in the US has grown at the slowest rate in our history. And the main reason is limited networks. The main driver behind that is that insurers are starting to tell people they can't go to those really expensive providers. So basically, the question is, to what extent, or is that part of your plan? Are you going to let people go anywhere they want, or are you going to limit where they want to go? And this is going to tie to another issue I'll talk about, which is insurer competition, insurer regulation. So that's, right there we have a ton of really hard questions, and we've just scratched the surface. The next set of questions you have to ask is, what is affordable? This drives economists crazy. This is not a word that makes sense in economics. Affordable is not a thing, okay? But it is critical in public policy. And in fact, once again, to bring back the example of Massachusetts, the law in Massachusetts, the vague law, said health insurance has to be affordable, but we're not going to define what affordable is. We'll leave that to the expert board. So the board I was on had to decide what affordable meant. So since I was the economist on the board, they looked to me. And I said, I don't know, but that didn't really work. So I had to come up with a definition. The definition I came up with was, I went to expenditure data, in the US we have excellent expenditure data, and I took people, I said, take out all their necessities: food, clothing, transportation, housing, utilities. And whatever's left is their budget space to pay for health. Their fiscal space, if you will, to pay for health insurance. Now that may or may not be a good definition. It's what I came up with, and it's what we sort of use to think about affordability. But that's an issue. How do you find affordability? How much are you going to charge people? So in India, you have a huge population that's desperately poor. So you think things should be free. And maybe they should be. But here an important political consideration comes in, which is that free is an absorbing state. Once something free, it's always going to be free. So once something is not free, as inflation goes up, you can raise the amount, which you should. Okay? But once something's free, there's no natural inflation. 0 times anything is still 0. And so while we'd like to make things free on social justice grounds, we have to remember that once something's free, it's never going to not be free. And that's an important consideration in setting up these kinds of systems. So let's say it's not free. How much do you charge? Well, any amount you charge is going to be wrong for everyone. It's going to be too low for many people and too high for other people. It'll be just right for one person. And for everybody else, it's going to be too high or too low. So a flat amount has that problem. So you say, okay, fine, let's go to a sliding scale, where people pay a different amount based on their income. Well, then you have an administrative nightmare, which is how do you measure income? So we're talking about using, for the new policy, using a measure of income, which gets us from 2011. Okay? Incomes have changed a lot since, people's incomes changed a lot since 2011. Even in the US, with our advanced data systems, when we evaluate people's income for Obamacare, we use data that's 2.5 years old. So basically, this becomes a real challenge. There's a trade-off. On the one hand, you need it to be sliding scale to be fair. On the other hand, sliding scale raises a huge amount of administrative issues, 100 times worse in India than in the US. So this becomes another sort of issue. And indeed, so anyway, so that's a set of issues. Then basically, so then there's, how do you set the sliding scale? Do you give people a percent of premiums off? Do you say you get 50% off the premiums? Or do you say you pay a certain amount of income? This is a big debate we had in the US. The conservatives wanted to say, under Obamacare, that people should get, say, 50% off their health insurance, or 60% off. So the poorer you are, the bigger discount you get. The problem with that is when health insurance costs vary across individuals, that means that the individuals bear the consequences of more expensive insurance. So if I give you 75% off, and you're poor, then in an expensive area you're going to have to pay more than in a non-expensive area, and you might not be able to afford it. That's why we worked hard in Obamacare to make it a percent of income. People pay a certain percent of income. So if you're poor, you pay 3% of income, and it rises to 10% of income. So basically, on a rising scale, they pay as a share of income. Was that the right answer? I don't know, but that's another kind of decision we had to make. So we have, what is insurance? Tons of decisions. Question? Yeah?
So what are the implications for affordability in an economy where informality is very high? I would assume that 60% were formal in the US, 20% were again formal in the US who had private insurance, and the rest 20% were informal sector.
No, in the US, it's much smaller than that. The ones without health insurance, actually most are in the formal sector. It's that their employers don't offer health insurance and they can't buy it on their own. But they work in the formal sector. Our formal sector is tiny in the US. But in India, you're right. How do you do this? I mean, basically, how do you set up a system where most people are informal, there's no credible source of reporting their income? How do you set up a sliding scale system? I don't know. It's a really, really tough question. And it may be that the answer is you can't. And it may be that despite my comment, you have to make it free. That that's the only feasible answer. Or maybe you have a tiny, tiny charge that everyone can afford. So at least it's not, so people bear some responsibility. But I think that is a really, the other thing to think about here, on this slide, this is very important, is, so the concern about making it free or very low cost is that then the rich people are getting too good a deal. That is actually an argument for making the health insurance not quite as good as you might otherwise. There's something in the US, we call this an argument, it's called the self-selection argument. Here's the way the argument goes. You want the rich to stay out. You don't want the rich in. One way to keep them out is to charge them a lot of money. But that's hard to do, because you can't tell who's rich. The other way to do it is to make the insurance not so great. And then the rich won't want it. So that's sort of an argument for not making the insurance as good as possible. It's a way to so you can charge a low price but still get rid of the rich by making the insurance not so great. So that's sort of another thing you can do. Does that make sense?
Or can the rich be made to pay for certain things like wards or medicine?
Exactly. That's what I meant not so great. Make the insurance be minimal, and then if you want better things, you have to pay. That's a great idea. That's another way to do it.
In fact, in Karnataka, they have a separate scheme for APL. It's called Auditorium. There, the same services are and coverage is made available for APL population. But, so it's for general ward.
Right.
So, but if they want a private ward, a better stent, better prosthesis, then they have to pay extra for those extra services.
So, and I absolutely believe that's the right way to do it. But to be fair, in America at least, that's very politically, saying that is very politically challenging. So I'm generally a pretty liberal guy. But on this board I was on in Massachusetts, I used to say things like that, and on the radio they'd call me a Nazi. Because I suggested people should have to pay, that rich should get more than poor. Okay? Now I don't know what the politics is like here, but there is a challenge with that politically, but I absolutely think that's the right way to set it up. I totally agree with that. Okay, so we've got what's insurance, what's affordable, how much choice should people have? This is a really critical issue. This comes to sort of the trust versus private insurance model at one level. But even within a private insurance model, how many choices should you? With the trust, obviously, there's no choice. It's just one government payer. With a private insurance model, there can be choice. Now, those of us who study economics understand we love choice as economists, and we love choice for two reasons. First of all, consumers can get the goods that match their tastes. Second of all, competition induces efficiency. That if you have insurers competing, they will become more efficient. That the monopoly insurer will be lazy and inefficient. But in the health insurance context, choice has two very negative flaws. The first is the problem of adverse selection, which is that insurers will try to avoid the sick. Indeed, if you look at US insurers before Obamacare, the main thing they spent their money on was figuring out ways to avoid sick people. Okay, there's the joke in the US we have about the third floor walk-up insurer. You have to walk up 3 flights of stairs to get there, then they'll sign you up. You know, basically the point is insurers want to avoid sick people. And that's bad because sick people, that leads to discrimination against the sick. That's one problem, the adverse selection problem. The other problem is what we call choice inconsistencies, which is I've done a lot of research on, which is that people aren't very good at making these choices. So in health insurance context we studied, only about 12% of people make the right decision about the best health insurance plan for them. Most people choose a plan which is much too expensive. So basically, for those reasons, choice has limitations in the health insurance context. So that leads to the question, how do we regulate insurers? If we're going to not have the trust model, if we're going to have the insurance model, how should we regulate insurers? So for example, one way to deal with adverse selection is risk adjustment. So the way that would work is, let's say Mita and I come in, and I'm twice as sick as Mita, so the insurer wants Mita, they don't want me. But what if we say to the insurers, we'll pay you twice as much to sign up John as Mita? Then they'll want me, because they're being compensated. That's called risk adjustment. In principle, risk adjustment can get rid of the adverse selection problem. In practice, it's hard. It requires a lot of data, it's hard to do right, but it helps. The US evidence is proper risk adjustment can greatly reduce the adverse selection problem. But it's complicated. That's one thing you can do to try to regulate insurers. Okay? But that has political problems. I'll give you a great story about that. So in Massachusetts, we announced before our plan there'll be risk adjustment. We said to insurers, the insurers that sign up to sick people will get money from the insurers that sign up to healthy people. So if you end up signing up healthy people, we're going to make you write a check to the insurers that sign up sick people. The insurer said, great, that makes sense. Well, ex post, the insurers that had to write the check were mad. And they had a lawsuit saying we shouldn't have to write this check. Despite the fact they'd agreed beforehand to write the check. So risk adjustment isn't as simple as it sounds. Then there's the issue of structure and choices. How much choice should you let people have? So in Massachusetts, when we set up our plan, people could choose across 110 different insurance options. And people didn't like it. They were confused. They didn't like the system. We narrowed it to about 25 different insurance options, and people liked the system much better, and they made better choices. Indeed, I've just finished a study where I looked in the state of Oregon in the US. I got data across 250 different school districts and looked at how good a job people did choosing their health insurance plan. And I found the fewer options there were, the better job people did choosing their plan. So basically, structure and choices is an important element too. Yeah?
In US, is there a problem for overconsumption that we provide for ensuring that people are not consuming more medical care than...
Absolutely. I mean, that's behind all that. I mean, that's in some sense comes back to the modeling. We call the inducement or moral hazard effect. It's critical. And if we think about the modeling that I'm doing here in the US, one thing we have to do is figure out how big is that? And that's where the kind of empirical work that this organization does do is really important, is to try to estimate how big is that inducement effect. Right now, I don't know. I'm just throwing an unknown in my model for that. But that's something I have to eventually model. That's very important. So regulating insurers. Then there's basically the question of competition versus regulation. What about the insurance prices? Are we going to regulate prices? Or we're going to let them compete? Now, if we regulate, the problem is we don't know the right level of regulation. By definition, we'll get it wrong. It'll be too high or too low. Competition tells you the right price, but competition is very imperfect. And in perfect competition, you're going to pay much too much. Okay? Now, there's an interesting idea here. I have a famous former colleague named Peter Diamond. He won the Nobel Prize a couple of years ago. A good friend of mine. And he is a very smart, too smart. He's so smart you can't understand him. Theoretical economist. And he became president of the Econometric Society, which is like the highest end organization in economics for all the super smart people. Okay? And he had to give the presidential address. And everyone was very excited for some big theoretical breakthrough. And his presidential address was a plan for national health insurance, which was great. I loved it. And what his idea was to say, look, competition among insurers is very destructive because of adverse selection. What if we had competition at the procurement level, but had a monopoly insurer for an area? So we have 600 districts in India. What if each district got one insurer, but insurers competed to be the monopoly insurer for that district? So there was still competition, but it was procurement competition, not consumer competition. Now, that has an advantage, which is you get rid of the adverse selection. Once I'm the only insurer in the district, then I don't care about avoiding the sick because I get everyone. It's like a mandate, basically. The disadvantage is, once I'm a monopoly insurer, I may have a fixed advantage. It's hard to displace me once I'm in place. But that's the kind of thing that we can be thinking about. Once again, another decision we have to make. All these different decisions we have to make as we think about this policy.
So in India we have that.
With RSPY, right?
Yeah. But then the thing that we see is, then the way for the insurer to control costs is to keep rejecting.
So that's another issue. I should put that up there, regulating insurers. There's a whole question about how much you regulate actual insurer behavior. Basically this comes down to who bears the risk. So if you put all the risk on the insurers, will they have an incentive to undertreat? I mean, you want some rejection. Some rejection is optimal, right? Because people might apply for things they shouldn't get. In the US, we found insurers overtreat no matter what. Even with all the risk, they still overtreat. In India, I'm not sure what
How did we undertreat?
Yeah. So basically, if they're undertreating, that means they're bearing too much of the risk. So you need to absorb some of the risk back off them. But the way you do that is with a kind of risk adjustment. You sort of say, okay, fine. Since you bear all the risk, you're undertreating, so we'll take some of that risk off you to try to reduce the extent you undertreat. Or you can try to regulate them and try to catch them undertreating. That's a lot harder.
What do you think about an idea for deductible for the insured?
So basically that's essentially them bearing initial risk. And then essentially that's what we call that reinsurance. So essentially it's a reinsurance model. That is a model of risk adjustment. That's an example of risk adjustment. The way that would work would be, we call that in the US, we call that risk corridors. The way the risk corridors work in the US is there's a certain target, plus or minus 5% of that target, the insurer bears all the risk. Once they go if their costs are more than 5% above the target, then the government picks up 80% of the risk. If their costs are more than 5% below the target, they have to pay 80% back to the government. So it's two-sided insurance. It's clearly some form of reinsurance is clearly optimal. Because the government, it's all about pooling. And nobody's a bigger pool than the government. So it's absolutely optimal to have some form of reinsurance. The question is, once again, in my list of things you have to worry about, where's the attachment point and how much reinsurance? Do you let them bear the first 1%, 2%, 3%? And once you start reinsuring, do you reinsure 50%, 80%, 90%? Or you have multiple tiers? Once again, great. I don't want to be too negative here. These are all really interesting questions. I just want to highlight there's a whole bunch of hard questions that we need to address as we think through health policy. It's a good point. And then finally, I've completely ignored the whole supply side of the medical market in this discussion. I'm only focused on the demand side. I've talked about consumers and insurers. What about the supply side? What about how many doctors we have? How many hospitals we have? How should we regulate the training of medical doctors? How should we regulate the behavior of doctors? How should we regulate their prices? And in particular, the fundamental big picture question is, what's the right mix of direct care versus insurance? What's the right mix? So if you look at the recent proposal, there's both. There's both the new National Health Protection Scheme and there's a big investment in primary care clinics, right? What's the right mix of spending across those things is a great question. So the bottom line is there's a lot of very hard questions here. And sort of what I really want to emphasize is that it's the role of organizations like this one to raise those questions and answer those questions. That basically politicians don't want to deal with this. They want to say big things like give everyone health insurance. Okay? And it's the role of organizations like this to say, okay, that's a great plan. Now here's the 100 questions you have to answer. And politicians will say, I don't know. And you say, okay, well, if you answer this way, the following will happen. You answer this way, the following will happen. And that's what the modeling that I'm doing jointly with NIPFP is going to try to do. The model we're going to try to do is to say, look, we're not going to tell you, politician, what the right answer is. You're the boss, you figure it out. But we're going to give you the budget constraints. We're going to tell you, here's the 100 decisions you have to make. And if you make them, given how you make those set of decisions, we'll tell you what it's going to cost you, what it's going to do. And then ultimately, the politician makes a decision. This isn't a political organization, it's an advisory organization. But the point is, we need to think about how we set up advisory organizations in the Indian, not thinking broadly, in the Indian context, that can play that objective role that CBO has played in the US. And it's not just the US. So for instance, and it's not just CBO. So for example, in the US, whenever we talk about tax reform, there's an organization called the Tax Policy Center that's been set up by some nonpartisan think tanks. And they have a model like this that provides nonpartisan objective answers to how tax policy will matter. In the UK, they have an organization like this. They have something called the IFS, the Institute for Fiscal Studies. It's run by academics, and they have objective reports on policies. So basically, it's a matter of doing the kind of reports that NIPFP does all the time, but putting them in the context of a more precise model that can answer these kinds of questions. So that's all I've prepared. I'm happy to talk for hours. So I can keep going if you want, but let me stop there and see if there's any questions about either this stuff or about the US reform or the Indian context or whatever. Yeah?
So one of the things we find interesting is we have put insurance versus direct care. But in India, I think the public goods in health should be in the model. In the sense that there are many, if you were to do this insurance model, the premium, whether it's paid by the government, will come out most probably out of sanitation, clean water, primary education, which have very good health outcomes. And I think India hasn't exhausted those completely. And I think that payoff is an interesting question, because what we have seen in history also, that whenever we do this, first we end up more towards provisioning of healthcare versus public goods. And when we do that, the most consumption that we get is out of, the most increases that we get is in salaries, sometimes to the detriment of medicine and equipment. So since the 70s to 90s, the largest increase in Indian government healthcare expenditure was salaries. And imagine this is the time when doctors become less important and MRI machines become more important. Medicine has today eaten up. So these type of questions, I think adding the question of where the money gets cut from is an interesting question because there's no fiscal space at all.
You know, you're reading your boss's mind. So when I proposed this last year when I came here for the first time, proposed this to Rajan, that was exactly what he said to me, which is, why do we care about this insurance stuff when there's sewage running in the streets? And I think the answer is that we care about both, and that ultimately we'd like to expand the decision space to include that larger trade-off as well. It comes back to your earlier question about valleys. You'd like to ask the marginal dollar, where should it get spent? Should it get spent in sewage, or education, or roads, or health? That's an even harder question, but it's not an unanswerable question. It's an empirical question. What you need to do is you need to study and ask, in the past, as the spending's varied across those different areas, how has it impacted health and outcomes? And that's part of my project I'm doing with Gates, is we're going to look at that.
Because my fear that is, if you give a very clear answer to this, because you are giving politicians a clear answer to this part of the debate, you will direct them towards this part of the debate. And that's a big danger. Because, sometimes if you give clarity in one part, if that part of the picture is clear, you direct people towards that because they think this is a complete analysis.
Well, that's a very, I agree with you, but that's a very dangerous position to take. Because that's a position that ultimately argues for no clarity at all.
No.
I mean, we can all agree the best thing is full clarity on every option.
True.
You're arguing there's a problem if you have clarity on one option, not others, and bias them towards that option we have clarity. I think we still need to move towards clarity as much as possible, but I absolutely agree that it should always be put in the context of this whole debate is having decided you're going to spend money on insurance, how should you do it? This is not saying your money should be on insurance. This is saying, having decided that, the first question, think of it as decision trees. The first question is how much is going to be in insurance. Now I'm going to help you with that decision tree and all the branches that are below it. There's a whole separate part of the initial decision tree, and I totally agree with that. But you're making a good point that we have to constantly be saying that too. Because if we don't say that, people will think, oh, we should just spend money in insurance, and you're absolutely right. But I think, once again, the goal of organizations like this should be to not only make that point, but to be able to provide an empirical answer.
Yeah.
And that's the challenge. But I don't think it's undoable. But I think that's the challenge moving forward, is to put some numbers and context on that. You also raised something else about the money all going to salaries. That's not obviously bad. Okay, there's a lot of evidence in the U.S. and other countries that if you pay doctors more, they do a better job. Now I don't know if that's true. I don't know the studies in India, but it is true the doctors here, at least in the public sector, do a terrible job. Okay, and it's not clear that that more compensation of doctors is totally a waste. It may be, but you were sort of assuming it was, but I don't know that it is. It may be that part of the reason doctors do a terrible job is because they're underpaid.
So there are 2 points to that.
Okay.
One is you will have to take a proxy for state capacity of making doctors work.
Right.
And that is an interesting value to put in the model for India. So the kind of state capacity in insurance regulation, medical regulation, we don't have a register of all licensed doctors. So
right.
Sometimes you find unqualified doctors in premier government education hospitals. So that is an interesting question to ask. And once you put a value for that, that would be an interesting thing. So recently I was reading a lot of our auditors, our GAOs, reports on government hospitals and government medical institutions. That might give you a nice indicator of proxy. For example, how much of the balance do hospitals unable to match in their financial statement? Compare that and you'll get a nice proxy of the state capacity. Basic
I don't understand how much of what balance.
So AIMS
right
was unable to match around 11% of its balance sheet.
Unable to match means what? They couldn't find the money.
Balance.
Yeah.
They mismatched the balance sheet by 11%. That's a nice proxy for state capacity. For now, you expect this organization to enforce doctors to work. It's an organization which cannot get left-hand side to right-hand side matching done. So, and that is just example of what I was reading last night, but it's a very interesting insight into the state capacity question of doing this. And there it might go right back to your first few questions, whether you want to do a deduction or do you want to do a benefits package.
Right.
A high standard deduction might just win in India if you put a state capacity proxy for enforcing doctors, anti-fraud.
But I think this also goes to your point. Let's come back to our tree.
Yeah.
So we've got education, sanitation, roads, health. Now we're going down the health branch.
Yes.
There's insurance, then there's spending on fighting fraud,
Yeah.
and maybe the marginal dollar is better spent fighting fraud than it is on insurance. That's the other. So each of these nodes, we need to try to put some empirical content. I'm not saying it's easy, but we need to try to put some empirical content on those marginal decisions. It's a good point.
Can I add something to you?
Go ahead.
Can I add something to your point? You're talking about public goods. So is there a way in which there can be some preconditions for the states? I mean, if you achieve certain level of public good, like for water, sanitation and all that, based on that, the fund obviously comes from the central government. Based on that, the fund is like,
It
transferred.
doesn't work for two reasons. One is that
One person
Sorry.
can have outside.
we can have it.
Yeah.
Thank you.
Yeah, he has a question.
Yeah.
So you made a comment in the passing that doctors in the public sector in India do a bad job. Do the doctors in the private sector do any better, or what is your comparative?
Well,
I
yes,
am
so
suspect-
we have a.
Is
you
that
may- you
is
may
that
know that-
anecdotal or a presumption or an assumption?
That's actually based on this recent study that Vishnu Das did. Many of you may know. So they did do you guys all know this? They did an audit study where they sent fake patients in to see the doctor. And the good news for the private sector is they did better than the public sector, about 50% better. The bad news is they still did a terrible job. It's just they did 50, it's just the public sector did a completely horrible job, and the private sector did a moderately horrible job. So yes, there is good solid evidence from a randomized trial that the private sector doctors are doing better, but they're still doing badly.
Also, one of the things we found with doctors.
Oh, I think this guy has a question. Yeah.
Complete you, I thought you wanted.
Yeah, no, actually, I have seen some of the questions which were asked in that randomized control
Right.
trial, and sometimes the kind of questions that are asked actually leads to a bias in the answers that would be expected, and also there is a difference in cultures maybe, in a rural area, like if you go, if I'm a sick person, if I go to a doctor, the doctor will generally ask me to say, bolo. And I heard in a seminar presented here when it was said that that's not the right thing to do by the doctor. But but that's precisely the right thing which the doctor does in India, to ask, please say. That means to please say ki what is it that is troubling you. That was taken to be an inappropriate question.
Interesting.
Which is actually not the correct thing or the correct way to interpret the answer or the question.
That's a great point, and any study like that has to make some subjective calls, and I think that's an excellent point. Clearly, it's not the last word. I think the reason I'm still probably fairly confident the private doctors are better is because people pay a lot more. I'm putting my economist hat on. People will pay a lot more to go to the private doctors. If they weren't any better, why would they do that?
Yeah, or maybe that those who were covered in that survey, the private doctors, were not necessarily from the slum areas or.
No, I think they did a good job of that, of balancing that. I think you raise a great point. They are not. What we'd like to do is we'd like to use something like health outcomes. We'd like to ask, but the problem is that's hard to do because people get to choose where they go. So I think you raise some valid points. I think overall, if you think about the motivation for that paper, the motivation was why are people willing to pay extra money to go to the private doctor? And the answer is it looks like the quality is better. So and that's why I sort of believe it, but I agree. I'm sure there's some limitations. You raise a good one.
It could be available in your public facility also. Private doctors are available much more, irrespective of their whether
Right.
they're degree or non-degree doctors. but privates are available much more as compared to public.
That's a good point too.
And in private, anyway, you have to pay entirely from your pocket, whereas
Right.
public is subsidized.
Right,
So anyway, out of pocket for private will be much higher than public.
right. That's a good point. Yeah, questions?
So, even if, let's say, the insurance program works excellently, we also want that the public health infrastructure generally improves.
Yeah.
So I'm saying that even if an excellent insurance model, we also want that the public health infrastructure generally improves. So how do we think about the money that is spent from the, like you have say, government sends say 10,000 crores rupees on insurance every year. So how much of that, is there a trade-off when we say that bulk of this money is going to private hospitals or is coming back to the public system? So in the latest data that I saw in 14-15, RSPY, 50% went to private hospitals, 35 I think was government hospitals, and 15% was administrative costs. So this breakup of where the money is going from the insurance pocket, like what are the questions to think about that do we need policy to direct it towards private or government, or are there any trade-offs?
That's a great question. You raise at least 3 different issues, so let me try to address them. One issue you raise is the question of basically the proper mix between direct spending and insurance. And that was sort of talked about, which is we don't know the right answer, we'd like to study that and sort of understand that. Another issue you raise is basically the issue of, is the administrative cost waste? And if there's 15% administrative cost, why shouldn't we just use the trust model? And there the answer is because the government has waste too. And the question, but this is something we need to study. A critical question is this trust model versus insurance model. We clearly know the disadvantage of the insurance model, which is 15% administrative costs or more. But we clearly know the disadvantage of the government model, which is, the government doesn't face competitive pressure to do a good job. And I think we need to be thinking hard about which of those, what are the pluses and minuses of those different models. I don't want to pretend, I guess I've said this to Nita, I view myself, I'm sure a lot of people come here and think they have the answers. I don't have the answers, but I do have the questions. So I don't think I have any of these answers, but I'm here to sort of raise the questions. And one great question you're raising with your question is, how do we think about this trade-off with the trust model and the insurance model? I'm sure it varies by state. Some states have better run governments than others. So in those states, trust model may make more sense. Here's a great example. In the US, we have student loans. You go to college, you get a loan. For a long time, we had 2 programs. One program was you get the loan directly from the government. The other program is the government would pay banks to make a loan to you. Now, it turned out the banks were making huge amounts of money on this program. And basically, there's no evidence they did anything special. It was literally just a waste. And Obama got rid of it. And it was a good move. The evidence is clear that the government was doing it perfectly efficiently. There's no reason to pay banks to do it. It's not clear that's the case with insurance. And that's exactly what you want. I think what economic theory might say is something like the model where they could, like the Peter Diamond model, where they compete, that hopefully if the competition is strong enough, they bid down those margins. But some of what insurers do with their administrative costs can actually be productive. So for example, in the US, many people say private insurance is terrible because our administrative loads are 15% for private insurance. But the public insurance, Medicare, their load is only 3%. People say we should not have private insurance, just have Medicare for everyone. What that misses is that Medicare doesn't do anything to try to make you healthier. Medicare just pays bills. Private insurers try to get you in programs, they try to manage your care to make sure you're going to the right place, stuff like that. And that's valuable. Now, it's not 15%, but it may be half of that. So I think this is a really, really, and in terms of our decision tree, this is an important node on that tree. Yeah, yeah. Really, after 4 times, there's still a question. That's awesome.
For the 4th time, but every time I hear you, I have an answer, another question. This is straightforward, and I think you once you already spoke about it once. But I still want to know, different countries have implemented insurance, health insurance, and achieved universal health coverage to insurance models. But we also know that the US model is particularly much more expensive than many other models of health insurance. What are those crucial parameters that you think are important to monitor to keep down the cost of the insurances, which in some sense US did not, or possibly you went and sort of made it very expensive?
I mean, fortunately, there's an easy answer to that question, which is price regulation. The rest of the world regulates prices in healthcare, and the US doesn't. And that explains almost all the difference between the US and, say, Europe. Is that basically we allow the free market to determine prices for things like doctors and MRI machines and other things, and the free market's failing. And the competition is perfect, and so we pay much, much more. Now, the answer is that, now the place people talk about that a lot is drugs. Now in drugs, the answer is not quite that simple. And the reason it's not that simple is because the high prices the US pays subsidize the R&D that makes new drugs. So essentially, if the US paid European level prices for drugs, there'd be a lot less R&D by the drug sector. There'd be less waste too, but there'd be a lot less R&D, and that's bad. Drug R&D is very productive. So I think, there is a bit of a trade-off, but I think if you ask the simple question, why is the US so much more expensive, but our outcomes aren't any better, the answer is that we don't regulate prices. Now, then you say, okay, great, so the US should regulate prices. Well, there's two problems there. Problem one is the politics, which is the doctors won't let it happen. So here's a great example. I love this example. So there's two types of drugs you can take. One is the kind you buy at the pharmacy. One is injectable drugs you get at the doctor, like for chemotherapy. So the way we reimburse injectable drugs under Medicare is when a doctor gives you an injectable drug, the doctor gets paid 7.5% of the cost of the drug. So if I give you a shot that costs $100, I get $7.50. If I exert the same effort to give you a shot that costs $1,000, I get $75. Stupid, right? Makes no sense. So 20 senators wrote a letter to President Obama saying this is a terrible system, we should fix it. So President Obama's team got to work on it. They said, we'll change the system. In a budget-neutral way. The new system will just pay you a flat amount plus 2.5%. We're not going to take away all the... We understand, look, it should be flat, but we understand people want some payment. So we'll pay you 2.5% plus a flat amount. Well, what happened? The cancer doctors, who were the ones giving the $1,000 shots, got really upset. They lobbied Congress so that 80 senators, including almost all of the original 20, wrote a letter to President Obama saying, this is a terrible policy. How dare you do this? You're destroying the freedom in America. You can't do this. And so we had to kill the policy. Here's a policy which everyone agrees is better. No one who's thought about it says it's a worse policy. But you couldn't do it. So that's the first problem with regulating prices. And that's why it is so important. It's very much like, I think there's so many parallels between healthcare and climate change. One parallel is it's much harder to fix climate change problems in the US than India. Because in the US we have to tear down a coal burning plant to build a natural gas plant. In India you're just building the plant for the first time, so you build it with natural gas. Similar with healthcare. We have to tear down a lot of things. Here you're starting, so you have a chance to get it right. So I'm excited to work here. And I think getting it right is going to involve much stronger regulation than we did in the US when it comes to prices.
I think doctors have captured India also quite well.
Yeah, well, I mean, that's absolutely true, but there's, the advantage you have here is doctors in India, my sense is, doctor pay puts them, a typical doctor is sort of in the middle class.
No, top 1%.
Top 1%. The doctors work in the clinics?
Yeah.
Then you have a problem. Now, that's a problem, yes. Now, but here's the other point, here's the thing you can recognize, which is that it's all about growth, not levels. Here's what I mean. India only spends 4% of GDP on healthcare. You don't spend too much on healthcare, it's not your problem. You don't want to be like the US, spending more than 10, 15, 20%. What that means is the doctors don't have to make less. It just has to grow less, more slowly. So in some sense, the whole point, the whole advantage when you think about price regulation is don't go to doctors and say we're going to cut your pay. Then they'll march in the streets. Say we're not going to cut your pay, but starting in 5 years, we're going to regulate how fast it can grow. They don't care about 5 years from now, but that's the key thing. The levels isn't what matters, the growth that matters. So that's how you do the of regulation. And that's how you bring it down from the top 1% and make the top 10%, is by slowing the rate of growth of their income. You know, I talk about, when I talk about this in the US, I talk about healthcare cost control. I say the two key words we have to keep in mind is to be humble and to be patient. Humble in recognizing we don't know the answers. And patient in recognizing it's okay to take a while to get the answer, to get it right. You don't have to fix it right away. Here's the problem. What two words least describe politicians? Humble and patient. Okay? And that's the problem. That's why the organizations like this are so important. To be able to say to the politicians, hey, we don't know the answer, let's take our time and figure it out. Question?
Also, just one small in the way. I'm just saying, after every $100 you spend in US in healthcare in this insurance model, how much is actually for the healthcare? How much would account for the profits of the insurance company and the profit of the private provider?
That's a great question. We know the insurance company answer, it's 15%. Now that's not all profits though. 15% load. But a lot of that's administration and other things. The profit rate for insurers probably have about a 10% margin, 10 to 12%. So they do pretty well, but not outrageous, not like Google.
In India it's 42%.
Yeah. So there's that. Then within the private sector it's much harder. Hospitals on average have very low margins. But that's a margin after you pay salaries, and hospital CEOs make millions of dollars. So in some sense, the rents don't go through the form of higher profits for hospitals. They go in the form of higher compensation for executives, administrators. And those can be quite high. But there's still a small share. Really, the truth is, the profits aren't the problem in the US healthcare system. The problem is the profit motive. It's not profits technically defined. It's essentially doctors being paid above their marginal value. It's not profit in the classical sense, in the sense that they're billing what they're being paid. It's just their bills are too high. So an orthopedist in the US, a good orthopedist can make $1 million a year. That's crazy. Yeah, you have a question?
I'm just thinking, so when we think about generous coverage, so do we also think about long-term care, mental health, or are those just...
That is a great question. That goes all the way back to my first slide, which is what's insurance? What services are covered? So let's take mental health. That's a great question. Many people, mental health, even in America, is a second-class citizen. We don't think of that as real health, which I think is wrong. I think mental health is just as important as physical health. But many people would say mental health, before Obamacare, insurance did not have to include mental health coverage. Now it does. So should that be included? That's like my dental example. Well, it's a trade-off. It makes health insurance more expensive, but it improves quality of life, and that's a trade-off. Long-term care is even harder. Now, in the US, health insurance does not cover long-term care. That's a separate program. That is at the same time, it's a big share. It's about 10% of healthcare spending in the US. So, that's a bigger challenge, because long-term care is so much more of it is not healthcare. It's food, it's housing, it's other things. So I think that's a really interesting question. The US health financing system for long-term care is kind of messed up. I think it's a chance for India to get that right. I think that's another branch on the tree, is what's the role of long-term care? Yeah.
I don't know whether this is a relevant question, but as compared to the US or the developed world, we in India have several different systems of medicine.
Yeah.
How do insurers actually address this? Are we talking only about allopathic treatment or kind of?
That is such a great and hard question. So, and it is so personal. So I thought acupuncture was bullshit until my wife went for acupuncture and cured her back pain. Now I think acupuncture is great. But insurance doesn't cover acupuncture. Should it? I don't know. It comes to this question of what's insurance? What should be included? Once again, in principle, we measure the quality of life improvement for every treatment and weigh it against its cost. Acupuncture is pretty cheap in the scheme of things. So the truth is, it would be pretty cheap to cover that. For the cost of one unnecessary back surgery, we could pay for acupuncture for 1,000 people. But in the US, we don't pay for you can have as much back surgery as you want, but we don't pay for acupuncture. In India, that's a much bigger challenge because so much of the healthcare that's delivered is not allopathic. And that is a really, really hard question. And once again, in principle, we'd like to do some studies that would allow us to understand the effects. Because remember, healthcare is not just about how long you live. It's about your quality of life. So for example, we did this great randomized trial in the US. We randomly gave some people health insurance. And we looked at what happened. What we found was almost immediately, their mental health improved enormously. But that can't be the medicine. It was almost immediate. It was the feeling of well-being. Okay, now I'm secure. Now I have health insurance. Depression dropped 30%. 30%. That's a huge benefit. But it wasn't from any medical care. So if somebody getting homeopathic medicine really improves their quality of life, maybe it should be included.
But I think in India, they are thinking of those lines because on the primary care level, they are thinking of building wellness centers where there will be some doctors who practice alternative medicine like homeopathic.
But then we have the flip side, which is where do you draw the line? Basically, the less well-defined it is, the more role for quacks. And that's the flip side. And the more role, and remember, the thing is, acupuncture is not a good example here because they stick you with needles. But a lot of alternative medicines, while not pleasant, are much more pleasant than allopathic medicine. And the key thing we're working on here, we mentioned before the idea of inducement. The idea is you cover something with health insurance, people use too much of it. Well, inducement for hospitalization is not that big a deal. No one wants to go to the hospital. But inducement for aromatherapy, that might be a big deal. Kind of like aromatherapy. It smells good, I have a good time. You know, for massage, that might be a big deal. So when we think about these things, we have to think about both the benefit, but also the cost in terms of inducement. And that's, you know, once again, I'm here to raise questions, not to get answers yet. But that's the kind of thing, I have a vision that we all get together in 5 years. And a bunch of these questions we've asked are answered. You know, and then we can then go to policymakers and say, look, once again, we're not going to tell you what to do, but we're going to tell you that we've learned that aromatherapy is useless, but acupuncture is useful. You know, that we will go and be able to get into those things. I had my first Ayurvedic spa.
Seriously?
And it was great. I don't think it made me any healthier. I feel pretty much the same. It was kind of cool. It felt neat to get rubbed oil over my body, but I didn't feel any better. I certainly don't think insurance should cover that, but other people swear by it. So, all right. Thank you very much.